Assalamu alaikum. My name is Myra, and here I'm going to discuss schizophrenia treatment failure. First of all, let me tell you what is treatment failure schizophrenia, or we can also call it treatment resistant schizophrenia. It is basically a failure to respond to at least two antipsychotics. And the issue of the treatment resistant is of particular importance for the practicing psychiatrist because 10% to 30% of the patient have little or no response to antipsychotic medications, and up to additional 30% of the patient have only partial responses to the treatment. So the concept of non-responsive to the treatment is multidimensional, as no response may be present in positive, negative, cognitive, excitement, or depressive symptom domains. These are some important factors to consider when evaluating a poor response, which include inadequate response may be caused by inadequate dosing, poor adherence, or true resistance to antipsychotic treatment. Second, a therapeutic trial of 3 to 12 weeks of an optimal dosage may be necessary to determine the full benefit from an antipsychotic agent. Third factor is we should monitor the blood level. Blood level monitoring may be helpful to identify the non-adherent patient as well as those in whom a pharmacokinetic factor may account for a poor response, like poor drug availability, rapid metabolizers, 78 to 26 psychiatric disorders, concomitant use of metabolism inducing agent. These are the proposed strategies we consider for change in the antipsychotic medications or insufficient efficacy, which include abrupt switch. What is abrupt switch? It is an abrupt cessation of the current drug with abrupt introduction of the new one at the expected therapeutic dose. Gradual switch. Slow downward adjustment of the dosage of the current medication with slow upward adjustment of the dosage of a new drug. Overlapping switch. Abrupt introduction of a new medication overlapping with the current medication followed by the downward adjustment of the dosage of the previous medication. Now let me tell you what are the different trials we perform in order to treat the schizophrenia symptoms. So the first trial, or trial 1, which is an onset of the schizophrenia symptoms, in which we take first line antipsychotic medications, adequate dose, duration, and adherence. There might be a chance that the treatment is responsive, or sometimes inadequate response is shown with this treatment. So we will initiate, if there is a inadequate response to the there is a possibility of the treatment resistant schizophrenia, but it is not confirmed. So we will initiate with the second first line of the antipsychotic medication. So now we will move towards trial 2, which is an antipsychotic medications we give to the patients with adequate dose, duration, and adherence. There might be a chance that the treatment is responsive, and if the treatment is resistant, or there is a treatment failure, then we are confirmed that this is a treatment resistant schizophrenia. And what is treatment resistant schizophrenia? As we have discussed before, that this is a persistence of the positive symptoms despite of greater than or equals to 2 trials of the antipsychotic medications of the adequate dose and duration, the documented adherence. So when we are confirmed that it is a treatment resistant schizophrenia, we will initiate with the treatment, we will give the drug clozapine. The trial of the clozapine may be responsive, and sometimes it is resistant. So we will consider the next trial, clozapine resistant treatment resistant schizophrenia, or the trial of ECT, in which we give the electroconvulsive treatment. That Through this treatment, there may be the response. This treatment may be responsive or sometimes resistant. We will call it as ECT resistant TRS, treatment resistant schizophrenia. Conversion from the oral to the depot therapy. The conversion of the following drugs may improve the response of the treatment. The first conversion is the fluphenazine deconate conversion. After stabilizing the patient on oral fluphenazine, multiply the total daily fluphenazine oral dose by 1.2 and administer as fluphenazine deconate IM every 1 to 2 weeks. Alternatively, 12 to 0.5 mg of fluphenazine deconate can be administered IM every 1 to 2 weeks for every 10 mg, rounding to the nearest 10 mg increment of the oral fluphenazine per day. Example, 25 mg per day per oral rounded to 30 mg per day and given as 37.5 mg of deconate. The second conversion is haloperidol deconate conversion. In elderly patients or those stabilized on less than 10 mg of the oral haloperidol per day should receive haloperidol deconate in an IM dose that is 10 to 15 times the oral daily dose every 4 weeks. If higher oral doses are needed for stabilization, then the first deconate dose should be 15 to 20 times the oral daily dose to a maximum of 450 mg. The first injection of the haloperidol dose deconate should not exceed 100 mg. Long-acting risperidone reformulation. It is recommended that the patient establish tolerability with the oral risperidone prior to the initiating treatment with the risperidone consta. In published clinical trials, IM doses of 25, 50, or 75 mg have been administered at the 2-week intervals. 141, 142, the schizophrenia, 78 till 27. Recommended dose is 25 mg IM every week. Oral therapy of the risperidone should be continued for 2 to 3 weeks after the first IM injection and then discontinued. These are the antipsychotics which we give in the condition of the possible TRS. If there is a confirmed TRS, then we switch to the clozapine. Clozapine is a gold standard for the treatment of the treatment-resistant patient. Considering the risk of agranulocytosis, the burden of the side effects, and the requirement of the white blood cells monitoring associated with the clozapine therapy, one of the other atypicals should be tried before proceeding to the clozapine. Clozapine is approved by the FDA for the treatment of the resistant schizophrenia or when the adverse effect such as TD and EPS preclude use of any psychotics. Clozapine is contraindicated in the patient with a history of myeloproliferative disorder, uncontrolled epilepsy, paralytic ileus, clozapine-induced agranulocytosis, or granulocytopenia. A current WBC count below 3500 mm3 or ANC count below 2000 per millimeter. Risperidone and olanzapine are also the atypicals other than the clozapine. In a double-blind trial comparing risperidone with the haloperidol, which is an antipsychotic in treatment-resistant schizophrenia, a significantly higher response rate favoring risperidone was observed at week 4, but not at week 8. In a 6-week clinical trial, only 7% of the patients prospectively determined to be resistant to haloperidol responded to olanzapine, a rate that did not differ from the chlorpromazine. In general, atypical agents other than clozapine have not been consistently found to be as effective in treatment-resistant schizophrenia. In some patients, clozapine is non-responsive or it shows an inadequate response. Some patients did not respond to clozapine after an adequate trial of at least 6 months at a therapeutic dose. In such situations, it is reasonable to prescribe the antipsychotics to which they had the historic best response. Augmentation strategies such as addition of the mood stabilizers, which are lithium and valproate, benzodiazepines, propranolol, antidepressants, or another antipsychotic agent may be attempted. Evidence for this approach is lacking. Treatment guidelines recommend reserving augmentation strategies for the patients who fail or cannot tolerate clozapine, although in practice these strategies are often tried before a trial of clozapine. In order to evaluate the drug responses, serum concentration monitoring is very important. Haloperidol's therapeutic range to be between 4 and 12 ng per ml. The recommended ranges for the flufenazine and the thiothiazine are 0.2 to 2.8 ng per ml and 2 to 15 ng per ml respectively. Evaluation of the clozapine trial suggests an optimal range of 350 to 420 ng per ml. 246 247 greater responses rates were observed in olanzapine patients whose plasma concentrations were greater than 23.2 ng per ml in blood samples collected 12 hours after the dose. Samples should be collected 5 to 7 days after a fixed dose and 10 to 12 hours after the last dose for the oral preparations. 2 to 3 months should elapse before samples are collected in patients taking depot preparations. Treatment adherence. Poor adherence with prescribed antipsychotic therapy is a significant problem in the long-term management of the schizophrenia. Reviews suggest that deviation, primarily underuse from prescribed regimens, occurs in about 50% of the patients with the schizophrenia. Recent advances in the medication treatments with atypical agents have produced fewer side effects, which some studies have shown has increased adherence. During any phase of illness, non-adherence with maintenance antipsychotic therapy places patients at risk of exacerbation of the psychosis, increased clinic and emergency room visits, and rehospitalization. Non-adherence to the prescribed regimens can also compromise patients' daily functioning and the quality of the life. Long-acting depot antipsychotics should be strongly considered for the patient's history of the non-adherence. Case study. JH, a 33-year-old man, was diagnosed with a chronic paranoid schizophrenia at the age of 21 and has been hospitalized 15 times because of his illness. He repeatedly presents in a paranoid and hostile state, complaining of the auditory hallucinations and the paranoid delusions in which the police and the people in his apartment building and are trying to kill him. His symptoms have prevented him from obtaining the employment and he has no close friends. He has been treated with the flufenazine 20 mg HS and perfenazine 48 mg HS, but has had only a partial response to each medication. After each discharge, JH stays out of the hospital for approximately 6 months, then relapses. Even with a good adherence, he currently is taking haloperidol 15 mg HS with only minimal improvement after 2 months of the treatment. What can be done to improve his response? Subject 33-year-old man. Object no lab objectives were given. By considering the following symptoms through this case, we assess that JH meets the criteria for the treatment-resistant schizophrenia, and the clozapine is a gold standard for the treatment of this type of patient. Considering the risk of the agranulocytosis and the side effects and the requirement of the WBC monitoring associated with the clozapine therapy, so one of the other atypicals should also be tried before proceeding to the clozapine. Plan. Treatment guidelines recommended for the patients with other atypicals should be tried before proceeding to the clozapine. Clozapine is contraindicated in patients with a history of myeloproliferative disorder, uncontrolled epilepsy, paralytic ileus, clozapine-induced agranulocytosis or granulocytopenia occur in WBC count below 3500 mm cube or ANC count below 2000 per millimeter cube. Clozapine also should be used with caution in patients who cannot tolerate anticholinergic effects, in those at the risk of the drug-induced orthostasis, or in the patients with significant renal or hepatic disease. Thank you.